Imagine your child, niece, nephew, little cousin, or your friend's child who is diagnosed with type 1 diabetes. If you don't seek treatment, it could be deadly, leading to many complications during their childhood and adulthood. Hi, my name is Vanny Marie Kalinawan. In this presentation, we will discuss about type 1 diabetes in children, the statistics, barriers and facilitators, and technological management. Type 1 diabetes is an autoimmune disease where the pancreas in the body is not making insulin. Insulin is a hormone created in the pancreas that controls the amount of glucose in the bloodstream. This is different from type 2 diabetes, in which the body cannot make enough insulin or not working sufficiently. The rates of new cases of both type 1 and type 2 diabetes increased between 2002 and 2015 in the United States with a 4.8% rate. Also, it has been found by CDC that within this growth rate, there was an increase among ethnic minority groups with type 1 diabetes. Another increase of 8.5 is for Asian Pacific Islanders every year with the same date by CDC. This is the era where Asian immigrants started moving to United States. Dealing with type 1D can be difficult, especially at a young age. Children with type 1D might not understand the concept, especially when parents don't educate them properly. Highest barriers are loss of control of diabetes, fear of hypoglycemia, work schedule, which is for parents, external temperature, and low fitness levels. Facilitators are being knowledgeable about diabetes, positive coping, planning skills, and reflective motivation, which is providing emotional support and cooperative problem solving. Furthermore, racial or ethnic minority groups have lower collaboration involving diabetes management and have poorer T1D adherence. Instead of pricking the finger with a needle, continuous glucose monitoring, or CGM, are wearable devices that insert a tiny sensor under the skin of the arm that measures glucose levels found in fluid between cells and transmits its reading to the smartphone. CGM monitors are more accurate than home blood glucose monitors. CGM will also tell you your current glucose and where it's headed. Next, when to take insulin and how much can be difficult. We have insulin pumps that are automated and come in small electrical devices. There's a tin tube attached to the skin in which the insulin pump is connected to. The CGM will constantly measure the blood levels, and when it detects low or high glucose, the insulin pump then adjusts the insulin delivery. This is to prevent hyperglycemia or hypoglycemia. Oops, sorry. So we talk about the basics of T1D, statistics, barriers and facilitators, and technological advancements. It is important to seek treatment and have good diabetes management to avoid complication, even worse, long term. Dealing with T1D is already difficult for parents and children, both physically and mentally. We have new technological advancements that assist and make things a little bit convenient. So my questions for you, with the new technology we have today, do you think we will be able to find a cure for diabetes, and why? Another question, not just for diabetes, but for all illnesses. Do we need to rely more on medical technological advancement for treatment, procedure, and more? Why do you think? Aside from increased cases on diabetic children, low-income African Americans with diabetes continues to rise.
Imagine that a couple of years ago, you were diagnosed with type 2 diabetes. Since you lost your job, you cannot keep up with visits to your primary care physician and are uneducated on how to control your glycemic events. Whenever your glycemic levels are concerning, you head to the emergency room because there's nowhere else for you to go. You feel lost on how to manage your diabetes and unable to afford the prices that come with being a diabetic. My name is Caitlin Haber, and almost 1 year ago, I started my job at Shands as a CNA. The scenario above is one that I've seen countless times. Since my job is to check blood sugar levels, I know the reality of what happens if people like this don't get the help they need. Today, I'm going to be presenting my special population, which is barriers and new technological intervention for African American diabetics. Unfortunately, African Americans are experiencing a lack of aid in diabetes management. Genetically, African Americans are prone to having worse glycemic control due to genetics and psychosocial factors, and also tend to suffer from more frequent and severe glycemic events. In addition, these populations are being met with a lack of education and empathy from providers. Also, throughout the last 13-year period, there has been an almost 54% increase in the mean price of insulin and other diabetes-related products. Due to these growing concerns, a change needs to be made in the African American diabetic community. Poor glycemic control can lead to a wide variety of issues. Hypoglycemia is associated with poor outcomes, increased costs, increased mortality, and inpatient hypoglycemia leading to approximately 38% higher costs. Along with these higher costs for patients also comes overutilization of the emergency room. Elderly African Americans display a higher rate of visits to the emergency room, and 11.5% of type 2 African American diabetics who seek out the ER for diabetic-related services use the ER more than once in a 12-month span. One recent piece of technology that could be a key in low-income African American populations is the implementation of sensor-augmented insulin pumps, which help to reduce the frequency of severe glycemic events through the detection of impending and prevailing low blood sugar glucose levels. SAPs have shown to increase quality of life expectancy by 2.16 years for individuals with increased risk of glycemic events and reduce the number of hospital visits and glycemic events that diabetics face. In one study conducted in 2019, the total cost of 3 different methods of glycemic controls were shown. As you can see, even though SAP is still the costliest intervention, with each additional hyperglycemic event, the cost effectiveness begins to show. And this is just for 2.2 hyperglycemic events every 100 months. When we keep increasing the number of hyperglycemic events per every 100 months, we see a major decrease in costs associated with hyperglycemic events, and potentially severe consequences of these events show that switching to SAP is likely to be cost effective. By distributing SAP into low-income African American hotspots, we would be saving the cost and the number of severe glycemic events. I'll leave you all with a question that I think is becoming more prominent throughout the creation of more advanced technology. Although these lower-income populations may have a strong need for the implementation of SAP, many individuals would still have difficulties with the cost. When creating new forms of technology, how would you propose the integration of technology into hotspot populations that may not be able to afford it? We will now transition into the discussion of another special population that suffers from a lack of health services, and that is Latin American farm workers. Thank you.
My name is Isabel Mihai. The special population I will be discussing in this presentation is Latin American farm workers in the United States. I have been exposed to this population over the course of the semester by working on a team under Dr. Norman Beatty to organize a health fair for these farm workers in Wimauma, Florida in December. This press release from a previous health fair provides details on the services provided to these farm workers and their families, many facing extreme disparities that will be discussed further into the presentation. I recently had the opportunity to take a personal visit to an organization that works to deliver services to this population specifically, and met some of these workers in the fields. So I've seen firsthand the resources that this population lacks. I'd like to begin with emphasizing the importance of Latin American migrant farm workers to the United States agriculture system. According to the National Center for Farm Worker Health, in 2018, 73% of farm workers were foreign-born, 49% of these farm workers were not U.S. citizens, and 22% had work visas. The U.S. Department of Agriculture provides these charts to display how the U.S. farm worker population is made up. As you can see, over half of these workers are Hispanic. And as we can see on the chart to the right, the trend is showing more and more foreign-born, unauthorized migrants are making up the agricultural workforce. Florida's agriculture sector is very reliant on migrant farm workers. 150,000 to 200,000 migrant workers travel annually to Florida, yet only 34,000 are living in housing that meet the standards of the law. As you can see on the chart to the right, Florida has the greatest proportion of foreign-born workers in their agriculture sector. This population faces many health threats. For example, 10,000 to 35,000 farm workers suffer from acute pesticide poisoning each year. Air pollution can lead to health problems like asthma, COPD, and even lung cancer. Heat illness is 20 times more likely to kill agricultural workers than any other workforces in the U.S. The housing that these farm workers live in often do not pass sanitation inspections, are overcrowded, have bugs and rats, and lack privacy. All of these can contribute to the spread of infectious diseases, skin conditions, high levels of stress, and increased mental health problems. This population faces extreme stress due to concerns of deportations, helplessness, and job insecurity, which explains why farm workers are 45% more likely to report elevated depressive symptoms. I'd like to emphasize the statistic that at least 75% of farm workers and as many as 90% of the children in farm worker families do not have health insurance. The biggest problem facing this population is the lack of access to insurance. Many farm workers are not able to receive health care due to their immigration status, which compromises their health. For many, they fear seeking out medical treatment as they do not want it to lead to questioning and possible deportation. The constant movement of this population seeking work in new places based on crop seasons makes it hard to establish any continuity of care or specific doctors. Many language and cultural barriers prevent these workers from being able to seek out health care. The cost and lack of transportation inhibits this population greatly. They often travel in groups and in vans and can't go anywhere on their own. Furthermore, they live in rural areas that make it harder to find doctors nearby. I will now cover ways to help this population. Health screenings upon hire would check for pre-existing conditions for these workers. On-site healthcare would eliminate the need for transportation and account for the difficulty in farmers being able to seek out doctors. This population is often underaccounted for in the federal census, leading to the lack of healthcare. Patient health records for these workers would enable them to easily transfer any records despite any language barriers and help with the continuity of care. Finally, education and providing resources would immensely help the farm workers. How can the United States promote health services to this population and ensure the safety and health of our agricultural workers? Thank you.